So the next topic would be lung cancer screening. And it's a pleasure for me to invite Giulia Veronesi to the podium to give a brief introduction before the case scenario. After this session, there will be a coffee break. The coffee break will be at the exhibition, okay, at the exhibition hall at the main floor.
Good morning to everybody. It's a pleasure for me to introduce this topic. As you all know, lung cancer is the main cause of cancer death in the world, in the Western countries, with more than 100 cancer deaths every day in Italy. And we all know that detection at early stage is critical to have good results in terms of survival and mortality. And as you can see here, we have 80% survival in screening cancer. And we have now 2 randomized trials defining the role of low-dose CT scan screening with reduction in mortality. One has been released in 2012 with US big, large randomized trial. And the second is in a European trial with reduction of even more death, like 30–40% in 10 years. And all these studies have limited number of screening rounds, 3 and 5. So the main critics to lung cancer screening is related to the safety and the risk of false positive and overtreatment, overdiagnosis. But according to our data and other groups, when you perform screening in a trial, you have good results in terms of high rate of stage 1 disease, low number of recalls, 5–10%, much lower compared to the NLST, low number of false positive surgery, very low number of overdiagnosed cases, and very low radiation-induced cancer. So what happens when we will have an implementation on a large scale? We must take in care that surgeons will have the responsibility to follow the diagnostic algorithm, maintain low the rate of false positive, reduce the risk of overdiagnosis and overtreatment. Thank you.
Thank you, Giulia. So now it's time for the case scenarios. So I would like to call to the podium the Europe team. The subtopic is the management of a screen nodule.
Yes, we have a 70-year-old male patient with past medical history of hypertension, COPD, diabetes, and coronary artery disease. He had a cabbage at the age of 16. He is a current smoker with 50 pack years. He was enrolled into lung cancer screening at age 70 with Cosmo 2 protocol and had unremarkable CT scan. We can see the image here. After 4 years after the initiation of a lung cancer screening, the patient had a severe cerebral injury requiring hospitalization, treatment, and long-term rehabilitation. He had acceptable cognitive and motor recovery, voluntarily abandoned the lung cancer screening process after 4 yearly negative CT scans, and he quit smoking. Here's the question from Team America. The patient comes back to your office 2 years after discontinuation of the screening process, looking for advice. He is afraid to have lung cancer. What is your recommendation? Number 1, you reassure the patient and discharge him. Number 2, you suggest a full clinical re-evaluation, PFT, complete blood work, including tumor markers and chest X-ray. Number 3, you suggest to continue the screening process and book him a CT for the following week. Number 4, you refer him to a local pulmonologist. On number 4, you ask for a PET-CT scan.
Okay. So it's time for the audience to reply and for the team to think. So different options you see here, conservative or not. 15 seconds. 10 seconds. So almost done. Okay. Up. So, Americas, give your argumentation.
So although we do believe that the patient is at risk of having lung cancer due to the fact that he has multiple comorbidities and advanced age, I believe that currently he's 76 now, since 2 years after abandoning the screening program. At this point, we would just reassure the patient and discharge him. We don't believe that he would be a surgical candidate in the future.
So the correct answer is?
We are going with 1.
1, okay. Okay, please go with this next question.
2 years after discontinuation of a screening process, 6 years from the beginning of the process, the patient undergoes a low-dose CT. A left upper lobe lung nodule, 1 centimeter size, is found incidentally. Complete clinical staging is obtained with CT and PET-CT. We can see the scans with 1 centimeter nodule and is with SUV of 2. The question for Team ASE is, what is your approach to 1 centimeter low SUV lung nodule which has appeared after 6 years of screening? Number 1, to continue the follow-up in 1 year. Number 2, no reason to continue any follow-up. Number 3, suggest percutaneous biopsy and or EBUS. Number 4, suggest surgery for tissue diagnosis plus minus lobectomy. And number 5, suggest surgery for tissue diagnosis plus minus segmentectomy.
Okay, 3, 2, 1, go. Again, some alternatives. Conservative, surgery. So, different arguments, pros and cons. Okay. Time is almost up. 4, 3, 2, 0.
We think the answer is number 3, because first of all, the size is 1 centimeter, which is over the 8 millimeter, and the guideline says if it is over the 8 millimeter, then and the patient also has the smoking history and also the underlying COPD, which means the patient is in the high risk group. Although it has a low SUV, then we think more management to get the biopsy or EBUS should be performed. So we think the answer is 3, not the 1. The follow for the 1 year wouldn't be good option for him. And the surgery will be too much invasive because the nodule has a low SUV.
Okay, so your suggested answer is number 3, correct? Okay, so it's time for the jury to score. Okay, next slide. Oh, I have to. Okay, so we have the jury to score the quality of the presentation from Europe. So 8, 10, Giulia is 9, Arvin 8, 9, 10, 10, 8, 8, 7, and 7. Good. So next, you're asked to score the Americas answer. Okay. So the quality and the argumentation for the answer from America. Frank? 7, 6, 6 Giulia, 7 Arvin, 6, 6, 5 David, 5, 5 Chida, and 8 and 7 Steve. Okay. The final score is for the answer from Asia. So ready to vote? Raise your paddles, Frank. 5, 10, 8 Giulia, 8, 8, 6, 7, 9, 10, 7, and 7. Okay, good. So it's time for the next scenario. So the subtopic is the management of early stages. So now it's time for Team America.
Good morning. Our clinical scenario is as follows. There's a 62-year-old female, had 2 hospital admissions for infective exacerbations of empyema in the past 2 years. She's a former 60-pack year smoker that quit 2 years ago. Using a combination bronchodilator and muscarinic inhaler regularly, her ECOG performance status of 1. And she's enrolled in our lung cancer screening program. CT scan is shown here, showing a pure GGO in the left upper lobe with the largest diameter of 1.5 centimeters and no solid component. The patient received a new low-dose CT scan 1 year later, which is shown here. Again, a part solid GGO in the left upper lobe, now with the largest diameter of 1.7 centimeter, also acquiring a solid component of 4 millimeters. Here we can see the coronal and sagittal views and the difference in scans over the year. So our question to Team Asia, which of the following statements is true? 1, due to the size of the nodule in the first CT scan at 1.5 centimeters, immediate action should have been taken at that time, either by percutaneous, navigation-guided, or surgical biopsy. 2, because of the growth in the diameter of the solid component is minimal at 2 millimeters, the best alternative in this case is to repeat the CT scan in 6 months. 3, despite the growth in the solid component, because its diameter is below 5 millimeters, tissue sampling is not necessary, and low-dose CT should be repeated in 3 months. 4, as the solid component is now 4 millimeters, tissue sampling is recommended. Anatomical segmentectomy is an acceptable resection for definitive treatment. Or 5, due to the growth of the solid component, the best approach in this case is to proceed with a left upper lobectomy.
Thank you. So again, 30 seconds, which might be enough, I think, for the correct answer. So please read carefully and make your arguments, pros and cons. 15, almost done. The audience is already voted. 5. Okay, time is up. Good. Please reply.
Our answer is number 4, because according to the CT scan, the main component of the nodule is pure GGO, and only the solid component is only 4 millimeter. And so first we thought we needed to make the right diagnosis. So we think tissue sampling it should be recommended here. And according to the location of the nodule, it is located in peripheral lung, and because it is GGO and the size is not that large, so and also this patient he has PG score is 1. We recommended anatomical segmentectomy for him.
So the correct answer is number 4.
Yeah.
Okay, good. So let's proceed with the second answer.
So continuing on, thoracic revised cardiac risk score shows no coronary disease, no cerebrovascular disease, no anticipated pneumonectomy, and serum creatinine of 0.9. FEV1 is 35% predicted, and the FEV1 to FVC ratio is 36% predicted. In terms of cardiopulmonary testing, VO2 max of 13.9. Change in VE over VCO2 is 37. The respiratory exchange ratio is 0.89. SpO2, 94% to 86%, and the end tidal CO2 tension of 24. Our question to Team Europe, which of the following statements is true? The predicted postoperative FEV1 is below 20%, therefore the patient is high risk and should not undergo surgery. 2, since the patient has VO2 max greater than 10, we should proceed with left upper lobectomy because the risk is acceptable. 3, the VO2 max and VE to VCO2 ratio slope results clarify the patient as intermediate to high risk, so a sublobar resection is preferable. Or 4, the VO2 max of 13.9 classifies the patient as intermediate risk. Based on this result, we should avoid lobectomy and offer sublobar resection.
Okay, ready for, I think there are some room for discussion here, but again, you will be scored about your argumentation and not for only for the correct answer. Okay, think carefully. Please.
The correct answer is number 4. The patient has a higher risk to be operated, but I will not exclude him from the operation, and I will go for this sublobar resection and not for lobectomy because of the COPD. Yes.
Okay, so your correct answer for you is number 4. Okay, good. Okay, now it's time for the jury to score. First, to score the presentation, the America presentation, and the questions. So we have got 8 and 10, 10, 8, 10, 8, 7, 7, 8, 9, 9. So very good score. And next, you're asked to score the answer from Asia. For the first question, it's number 7. So we got 7, 9. Giulia is 8, 8, 8. Alessandro 7, David 7, 9, 10, 8, and 8. Okay, and finally the answer from Europe for the second question is 5, 5, 6, 7, 9, 9, 9, 6, 7, 7, 7. Okay, thank you. So now we move to the third scenario. So the management of ground glass opacities. So we chose, of course, Asia. They are experts in this. And so please come to the podium and present your case scenario. Don't rush.
The 73-year-old male with heavy smoking history was referred to our department with history of chronic cough. After chest X-ray, he received chest CT scan. CT showed 2 part-solid GGO lesions. The first one was at left upper lobe, S1 and S2. Solid component was 9 mm. And second one was the right lower lobe, S6, and solid component was 6 mm. The CT scans are as above. CT-guided biopsy of the left upper lobe lesion was suggestive of adenocarcinoma, and no genetic mutations were detected. So this question is to Team Europe. Which of the following is not correct about the GGO progression? 1. Malignancy rate is around 60% for part-solid GGO. 2. Malignancy rate of pure GGO is around 10%. 3. Most of the non-solid nodules detected on the modern thin slide CT scans are non-transient. 4. In view of slower growth rates for non-solid tumors, active surveillance for more than 2 years may be prudent for non-resolving nodules.
Okay, so it's time for thinking, time for the audience to reply. So take your time, think carefully, and express your opinions. Okay, 10 seconds. Good. Team Europe, it's your turn.
Yeah, we have a huge discussion, and we go for number 4 as well. We are sure that the first one is true, that the malignancy rate is around 60% for part solid. Number 2 is as well right, and the free one too. So we think that in view of slower growth rates, for non-solid tumors, active surveillance for 2 years may be the prudent for non-resolved nodules.
Okay, so you're going for number 4, right? Correct? Okay, number 4. Just to make sure that you get the right answer. Okay, so second question.
So the second question to Team Americas, which of the following is not correct regarding management of the solitary pulmonary nodule? 1, when pure GGO less than 5 mm is found, no routine follow-up is required. 2, for partially mixed GGO more than 5 mm, the tissue sampling or surgical resection should be considered. 3, for partially GGOs measuring 8 to 10 mm, further evaluation with the FDG PET-CT is advisable before more invasive procedures. 4, in case of partially mixed GGO less than 5 mm, no routine follow-up is required.
Okay, again. Time, okay, very good. No, stay here. 20 seconds. Again, a kind of articulate question requiring a very good argumentation for the pros and the cons. And same for the audience, just voting. Good?
So after our discussion, we're going with answer 4, and the reasoning as follows. For number 1, if there is no solid component, we do not recommend routine follow-up. For any lesion with a solid component, there is a risk of malignancy. So we believe that answer 4 is correct here, that the patient would need follow-up, and this would be a wrong answer.
Okay, so the correct answer for you is number 4. Good. Okay, you can go there. So it's time for the jury to express their opinion. First, we ask you to score the quality of the presentation from Team Asia. So it's time. Got 5 Frank, 9 Giulia, 9 Arvin, 9 Walter, 8, 5 from David, 9, 10, 8, and 7 from Steve. Got it? Good. Second is score the answer from Europe to the first question. So Frank is 6, 8, 6, Arvin 6, 9, 7, 6, 6, 7, 6, and 5 from Steve. Okay. Finally, you're asked to score the answer from America. So it's time to vote. Frank is 5, 9, 5 from Giulia, 7, 8, 8, 7, 6, 7, 9, and 9. Okay, so we finished the 3 case scenarios. So I call Giulia to the podium to reveal the correct answers and to give the supporting evidence for the correct answers, or if there is some questions about them.
Regarding the management of screening nodules, the question 1 is related to the patients come back to your office after discontinuation of CT screening. What do you do? The correct answer is suggest to continue the screening process and book a CT scan. The reason is because it's in the 60s of age and require additional screening. The guidelines says around 75 to 80 years old, even if you keep smoking. So the second question is, what is your approach to 1 centimeter low SUV lung nodule that has appeared after 6 years of screening? So the correct answer here is suggest surgery for tissue diagnosis and lobectomy. This is what the guidelines suggest, even if the nodule is very small, so discussion is open to consider also sublobar resection, and these are the literature. In this case, a preoperative tissue diagnosis cannot be obtained, but it depends on the capability of the radiologist. So a left VATS, wedge resection and frozen section of the nodule is performed. A diagnosis of non-small cell is obtained from pathology, and the left upper VATS lobectomy with systematic lymph node dissection was performed with the final pathology of T1b and 0M0 are 0.
So maybe the message is not to rely too much on the PET scan.
Yeah.
Yeah, might be one message. Because one of the supporting argument that you gave was the low SUV for the PET. But again, this was an adenocarcinoma, so it's not very reliable in terms of the decision to operate.
Yes, SUV2 for a very small nodule is pathologic. And regarding management of early stages, the question which of the following statements is true. The answer here is, as the solid component is now 4 millimeter, tissue sampling is recommended. Anatomical segmentectomy is an acceptable resection for definitive treatment. We all know that when you have the appearance of a solid component, it's the moment that the tumor or the precancerous lesions become invasive, and so it's the moment you have to do actions. And in this case, we had a VATS apical 3-segmentectomy with an eventful procedure, patient discharged on the 3rd postoperative day, and the final pathology was in minimally invasive adenocarcinoma, T1a MI, and so probably the correct answer is segmentectomy.
Oh, sorry. If I can add something, you've seen that there was a very good correlation between the histological component and the solid component of the CT scan. So it is very important for the staging to measure the solid component, which has been demonstrated to correlate with the invasive. This is a message, of course, for the juniors.
So this last question is related to which of the following statement is true? Is the patient with a very bad FEV1? And the answer is related to the VO2 max and VOC2 slope. Results classify the patients as intermediate to high risk, so a sublobar resection is preferable. So here probably discussion can be open because it's a very borderline patient, so maybe non-surgical treatment can be considered in some occasions. And regarding management of ground glass opacities, which of the following is not correct about GGO progression? The right answer is most of non-solid nodules detected on modern thin slice CT scans are non-transient. So not correct because most of them are transient and disappeared. So you always have to check with additional follow-up if you have a ground glass opacity to verify if not phlogistic, for example. And all the others are correct. This has been said. Which of the following is not correct, again, regarding management of solitary pulmonary nodule? When PUGGO is lower than 5 millimeter, no routine follow-up is required, is correct. So the correct one is for parasolid nodule, mixed GGO more than 5 millimeters, the tissue sample or surgical resection should be considered. This is not correct because it's too small, so you have to wait and make additional follow-up. So this is the not correct answer. The 2-stage surgery was offered to the patient. The first surgery was performed on the left upper lobe to preserve lung parenchyma. Left upper division segmentectomy was performed. He underwent right S6 segmentectomy after he recovered from his first surgery. So bilateral ground glass opacity has been treated with a double bilateral segmentectomy. So this is the correct way to treat multifocal lung lesions and not consider inoperable when you can treat them surgically.
So let's see what the audience replied. So for the first question, can I have the results? Oh, here. Yes, was the correct answer. It's not displayed here. It is kind of split, and the correct answer was not chosen by the audience, as you can see here. The next. Okay. The side, yes, there was a concordance between the right answer and what the audience replied. Okay, next. Again, yes, the audience replied correctly. About the progression, there was a kind of split between the audience and, but again, most of the audience participants chose the correct answer. And finally, yes, here there is a controversy, okay, completely discrepancy between the audience and the correct answer, the supposed correct answer. Okay, good. So it's time for a take-home message from Giulia.
So now that the evidence is there that lung cancer screening is effective, and we have a number of scientific societies that recommend lung cancer screening, the main topic and issue is how to perform screening, not anymore if to perform or not. So how to perform screening? We have learned a lot during these years of experience and research about lung cancer biology. So in the future, we expect a very large number of very small tumors. So our goal is to adapt the surgical treatment or any treatment to what we found in terms of prognostic factors. We know, for example, that volume doubling time is a prognostic factor that is not yet taken into consideration to define the extension of surgery. But if you can see here, you can have that all the stage 1 disease in the survival curves and at different risk of recurrence according to the volume doubling time of the nodule. So you can have same size but very different aggressiveness of the tumor. So in the future, we must be more experienced in identify these prognostic factors and make a tailored surgery for the good candidate. So we can have a very slow-growing tumor and decide to do only a wedge lesions or to do a segmentectomy with the new technology with, for example, indocyanine. And in additional cases, we can decide for sub in case of very, very slow aggressive tumor. In terms of extension of resection, today we have retrospective data that show how sublobar resection is similar in terms of survival to lobectomy. However, today we are waiting for the randomized trial to give definitive answer to sublobar and lobar resection. And for the moment, our clinical guidelines are to offer sublobar resection to cases with multifocal lung cancer or high-risk cases with all elderly patients, selected cases when you have recurrent tumors, or tumors less than 2 centimeters where a segmentectomy can achieve at least a 1-to-1 parenchymal margin and no regional lymph nodes. So how to complete and implement lung cancer screening on a large scale was the topic of a meeting last November in Milan, and that involved a large number of experts in Europe and outside Europe. So what the consensus agreement reported here is that the risk prediction model will be used to select the target population, or the Liverpool model or the PLCO are both validated models. The success of screening will depend on the correct management of nodules, and most of the cases will be used software for volumetry, grow rate, and identify the right cutoff size to perform additional exams will be critics. So we need to implement CT protocol quality assurance and national reference centers. For the screening timing, we know that today the current annual screening is recommended, even if we have good and promising data regarding the biennial screening, but for selected patients with very low risk of cancer. Of course, smoking cessation should be incorporated into CT screening programs. And in the future will be important to implement also the cardiovascular prevention using calcium score and COPD early detection. Of course, CT screening should be part of a defined national program, and large volume centers should be the reference centers with minimal invasive program for the treatment. And for every positive case, a multidisciplinary discussion is required. So we know that implementation of screening in Europe is an urgent need. We know that the cost-effectiveness analysis performed so far are favorable with possible affordable costs. And so we are working with politicians to implement screening at a policy level. Thank you.
Okay. Thank you, Giulia. So we have a couple of minutes. Maybe I can ask if any of the panel jury can comment on this important topic, which is lung screening. Maybe Frank or Walter or any of David or any of you, if you have any comment on the cases and on the management of the screen nodules or early stages.
Well, I would reinforce the comment about PET. You know, PET intensity is reflective of the biology of the disease, but it is dependent on size. Once you get below 2 centimeters in size, the amount that the machine detects is very affected by the size. So a 1 centimeter lesion that has a relatively low SUV of 2 is actually very suspicious for a lot of metabolic activity in that lesion. And I think in general for GGOs, I think you generally have very low PET activity. I think PET is not useful. I think it's a waste of money for primarily GGO lesions.
We have seen in the difference of the answers from the audience that especially in GGO with some solid components, there is obviously not a clear opinion how we should manage them. I assume there are also differences, at least between Asia, Europe, and maybe the United States. And there I assume we need a little bit more of education and science to bring in that we get a more uniform opinion how we should manage them.
Can I just add to that? I think that it's a very important point. I think that we have to be looking at thin section CT scans, 1 millimeter collimation slices. I think thicker scans, you really can't make a statement about the solid component or not. I also think that we should become more sophisticated, and I think there's a difference between a consolidated heterogeneous GGO on lung windows and something that has a solid component on mediastinal windows. I think a number of papers have started to define that, but I think we need to start looking at these details if we're going to try to develop better consensus about this.
I think the lung cancer study group trial is now a quarter of a century old. I think that our reliance on lobar lung resection should be reviewed. The disease is changing. It's becoming more multifocal, and particularly we avoid lobectomy of the lower lobes in these sort of patients, and we already perform many more segmentectomies than we did. I think this reliance on this historical trial should be reviewed. We're not waiting for the results of the new trials. We advocate segmentectomy in these small lung cancers.
Okay, thank you very much for the panel. So it's time for a coffee break. We are perfectly on time.